Hi, I'm Arthur Cummings from the Wellington Eye Clinic in Dublin, Ireland, and we're going to be speaking about a session that's just wrapped up that we really enjoyed on cracking the code for lens replacement.
Hi, I'm Ali Nowrouzi, corneal refractive surgeon based in Spain, Marbella, and we recently finished. We have wrapped up fantastic sessions regarding the lens and patient satisfactions and new, technologies that we have available.
So, Ali, thanks for joining us. You know, you and I both spend our time in this space, and yet we still learn something.
Great.
So, from the session we just attended, what's the main learning you took away?
Yeah, doctor. It was a very interesting session for me as well, and it was I learned a lot about how we have to indicate the lenses, how we have to escalate the patient. Challenging patients for multifocal technologies or maybe refractive lens exchange, cataract surgery with premium lenses, and how we have to differentiate different type of personalities, how we have to tackle to the complications, and for example, dry eye about how to manage it, about the dysphotopsia, we have to help our patients to go through these process of neuroadaptation, and also diffractive errors. Another thing that they didn't discuss about detachment of vitreous, posterior vitreous detachment, that I found it every day challenging in my daily cases that we have to also address, and also the difficulty of each patient. How you interpreted it?
Yeah, I was quite inspired by the fact that people are thinking more now with the patient in mind first. So first considering lifestyle, what your needs are, and then once you know what the patient wants, then looking at the anatomy, the physiology, and trying to see what the best fit's going to be, also from a neuroadaptive point of view, and then finally choosing the best compromise for that patient. So I agree with you. I think that was a very nice shift. There was quite a lot of consensus there, so most people are thinking along the same lines. You're right, there was a very good talk on the 3Ds, and the one we didn't pick up on was the dysphotopsia we get from floaters. So how do you assess patients regarding the vitreous prior to considering a diffractive multifocal or a lens technology?
Okay, it's really challenging. So we try to address it before the surgery, diagnose it correctly, show the patient, even with the images, to help them to learn what they have and what would be the problem. We try, if they have a very dense posterior vitreous detachment, we try to indicate the newer technologies like full range of vision, non-diffractive technology to prevent problems. And if they have already implanted, they have implanted any kind of diffractive lenses, we try to help them. Maybe some with new technologies like laser vitreolysis, and try to help them. In some cases, extreme cases, we had to do posterior vitrectomy, as you had also these cases. How you tackle these cases? Also, they're really challenging. How you tackle these?
So I think you're right. Like with any of these procedures, you first address the issues before they occur. Mm-hmm. So you discuss with the patient. So someone who's had a recent PVD and it's sitting right in front of them and they're already symptomatic, we're not thinking diffractive trifocals at all. You think of a different approach. I think what's more difficult sometimes is the patient who does not have a PVD at all, and I've got to make that decision. So for them, we'll tell them that at some point it's a natural occurrence, that the jelly's going to come loose. The fact that you're having lens surgery now might even accelerate that process. When it does come loose, for a while, you're going to be more symptomatic thanks to the fact that you've got a diffractive trifocal. But again, as we picked up in that session, is the more informed the patient is, the less surprised they are by unwanted side effects. So overall, isn't it fantastic that you and I spending all our time in this space, we still come out of sessions learning things?
Yeah, sure. It was a fantastic learning for me. And even the last talk was also interesting, the new indication for phakic lenses post RK, post, multidisciplinary approaches that these days we try to offer the patients, like intact curves, topo-guided laser, and then just to tackle the refractive problem in these cases, then we do phakic lenses. How do you think about these approaches?
I think that's amazing.
Yeah.
I think that's fantastic. We did touch on the topic because it's difficult about toric IOLs, where you've got to consider the cornea. Exactly. But a toric ICL is different because it's purely a refractive procedure. So you can sometimes, for a patient with advanced keratoconus, implant a toric IOL ICL, because that's what gave them the best vision in the phoropter.
Exactly.
Listen, I really enjoyed our chat. Thank you so much.
It was a pleasure. Nice to be with you. Thank you.